Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Do you live with pain daily? Is it affecting your ability to live life to your fullest potential? Are you afraid that you will never feel good again? I read this morning that chronic pain affects 100 million Americans today, or somewhere near that. It might have been a couple years old, but it's 3 times more prevalent than people suffering from diabetes and 10 times more than those with cancer. If you are a pain sufferer, stay tuned, because I'm Jean Pete. Thank you so much for being with me again this week. We have a very important show to offer you. I have Michele Chen here today. She is a nurse practitioner at North Fulton Pain and Spine Center. And there's all kinds of stigmas out there about pain centers, and I want to get rid of those because there are too many people suffering with pain in our country today. So, Michele, welcome to our show.
Thank you very much.
I look forward to talking about all things pain management. Not everybody is a drug seeker.
No.
They are in pain.
Absolutely. You're absolutely
right.
right.
So I can't wait to talk to you and find out how you maybe can help where other people haven't been able to help. So again, if you're suffering with chronic pain, stay tuned. This is a very important show for you, or if you know anyone suffering with chronic pain. So Michele, tell us a little bit about yourself and how you got involved as a nurse practitioner specializing in pain.
Sure. I graduated from the University of Maryland, and originally I had a scholarship from the American Cancer Society to go to school up there. And originally I thought I wanted to do oncology, and when I came back down here from Maryland, I decided to start looking at other different fields. Originally I got into rheumatology, and with rheumatology we do a lot of osteoarthritis, rheumatoid arthritis, and that's where a lot of my love of trying to help patients in pain started from. I went to work for a little while over there, and then when my sons got old enough, I started to look for a different job that would be closer to where they went to school. And one of them I was very lucky to find.
We do that? We live our lives through our children for the whole rest of our lives.
Exactly. And then I was very lucky to find that the North Fulton Pain and Spine Center was looking for another nurse practitioner to help them with their chronic pain patients up there. So I interviewed with the 3 fabulous doctors that I work with, the nurse manager up there, and absolutely fell in love with the way they were treating all of the chronic pain patients.
What do you think? We're going to talk a lot today about chronic pain because it drives me crazy. You're always hearing people talk about drug seekers, drug addiction.
Absolutely.
And I really think there's a difference between someone who's addicted and someone who is in pain who just wants to be normal.
Absolutely.
They don't want to be high.
Absolutely.
They want to be normal.
Absolutely. You're absolutely right.
And there is a difference. And I think sometimes we are, and I say we're in healthcare. We are so worried about people being an addict. And when we don't understand what is the cause of the pain,
right?
What is it that's really going on with this person? I'm so tired of people saying, oh, well, you know what, it's psychosomatic.
Right. You're absolutely right.
And we send people off, and then they feel like they have to go on the streets to get comfort because we're not taking care of them as a healthcare community.
Right.
So who's your typical, I know that's a loaded question, typical chronic pain patient, and how do you help them?
So a lot of our patients that initially come to us are patients who have had surgeries. A lot of them, I would say a lot of our patients are ones that have had back surgery specifically. We do deal with a lot of other chronic pain issues as far as headaches, abdominal pain, knee pain, joint pain. But most of our patients are the ones who have either injured their back, had some type of fall, some motor vehicle accident. As we get older, some of our patients have fallen and had compression fractures, and they eventually at first are put on some type of acute pain medicine, possibly in the hospital or post-op. Afterwards, some of the patients will find that their surgery really didn't help them as good as they were hoping it was going to, or that what the game plan was, if you will, to begin with, didn't really
Oh,
work.
and that's such a risky surgery, too. We had a doctor on. I'm so blessed to have this show. I get to interview experts all the time who is working on a new technology that he's only one of like 2 in the state of Georgia and 10 in the country, where it's so much less invasive. They don't have to open the whole back up.
Exactly.
But no one's really using it yet.
Yeah.
Not enough people. And back surgery is a tough decision.
Oh, gosh, absolutely.
And I did my research before you came. I hope you're proud of me.
Yes.
But I was reading that the most common pain condition is that low back pain.
Yes.
And they said 27% of chronic pain sufferers have that low back
Absolutely.
pain. And then what you said as well, severe headache and migraine pain is next with
next.
15%. And then this one kind of surprised me, neck pain. I wouldn't have thought of that. 15%. And facial aches and pain, 4%. I wouldn't have guessed those two to be in the top 4.
Oh, absolutely. I would say we have a lot of our actually patients come in. The neck pain a lot of time can be related also to the headaches. So
that's
you
right.
get you get a lot of your neck pain, and then the muscles that are in the back of the spine go up into the top of the head. And if you're having spasms from your back of your neck, it causes some of the head to pull, and there to be pretty bad headaches starting for the patients too.
And we're gluttons with neck pain. I remember when I had my baby, you carry them on your hip, and it was always the left side.
Absolutely.
And I started getting headaches, and they said, put the baby down.
Absolutely.
And then backpacks at school, and the way we carry our laptops and lug our luggage through airports.
Absolutely. And then you have just even your normal things where people were doing, as you're saying, for instance, you have teachers who will have a lot of pain from their necks, from their shoulders, from their elbows when they're doing work on the active boards or the chalkboards with the students. You have a lot of police officers having back pain from the lower back area because they have on the heavy belts that they're always wearing in the police cars. So a lot of what people do on a daily basis will add to their pain.
So I want to talk about what you can treat in terms of chronic pain, but how do we avoid getting there? It seems like it's daily living that it's just going to happen to us.
Just even the everyday things in which people, unfortunately, if they sleep wrong, they'll wake up with what we used to call kinks in their neck or things like that. So just the way to where people can more holistically take care of themselves. I think that with everything being so busy in our lives nowadays, we're so used to just running all the time and doing our daily thing and not paying as much attention to ourselves as we used to. But little things that people can do, like hot cold patches, warm baths, anti-inflammatories.
Who takes a warm bath anymore? Who has time? I would love it.
Exactly.
And people sometimes say, Jeannie, why don't you go up and take a bath? What? I can't sit for 45 minutes in a warm bath. It's sad.
There's things to do.
It's sad. My brain will go. I got to cook and clean. And anyway, it's a good idea.
Exactly.
Okay. And in stretching, I think, probably. We don't do enough of that.
Absolutely.
Just
Stretching.
take 10 minutes in the morning, 10 minutes at night, a couple stretching exercises. Get your muscles moving.
Walking through your neighborhoods after work just to release, first of all, some of the stress and keep those muscles moving, keep the joints lubricated, things like that. Sleeping properly, getting different pillows every so often.
How do you sleep properly?
A lot of our patients will sleep. It depends if you are a side sleeper. If you're a side sleeper, it's best to put a pillow in between your legs just to align the back a little bit better. Rotate out the pillows every so often that you sleep on so they're not totally flat against the mattress. Things like that, where you want to elevate the neck a little bit more so that way it's in a little bit more alignment. A lot of our patients who were back sleepers and then have back surgeries have found that they'll have to flip many times from side to side, just little things like that where they can reposition themselves too. Because it's kind of a catch-22, because if you're sleeping and you get a great night's sleep, you wake up sometimes in the morning and you're just thinking, oh my gosh, everything is hurting because I was in such a deep sleep I didn't move. And then on the flip side of it, for people who have to reposition a lot, they're not getting into that deep sleep cycle anymore. So it's really hard for a lot of people to get that deep sleep, which is really great for the body to heal itself and then also to help with pain.
Mm-hmm. But I guess if you're in that deep sleep you get the sleep you need, and then before you even get out of bed, do some stretching.
Exactly. Absolutely.
Yeah.
Some stretching. Absolutely.
Okay, so now that we know the majority of pain sufferers have back pain, a lot of headache pain and
Yes.
other pain, how does this work? They come in, and what do you do on their first visit?
Okay, so first thing I usually have always told our patients, and even if we have patients that are moving to different parts of the country, I always tell them you want to make sure you find a pain clinic that is tried and true. You want to make sure that when you talk to them on the phone, they're going to say to you, I need records from your doctor. Let's see what an MRI says, a CT scan. Have you had any x-rays? What else have you done? Let me pull your records, bring them to the doctor, and see what we can do for you first.
Okay, let's talk about that. Let's get the elephant in the room out of the room. Because you're always hearing on television about
Yes.
these pain clinics.
Yes.
And there's raids here in Georgia all the time.
All
There
the
was just
time.
another recent one.
Yes.
So that's a little scary now, because I feel like
Sure.
people who are in pain aren't even going to want to go to a clinic.
Absolutely.
Because now they're going to get labeled a user.
Absolutely.
Which is a travesty in and of itself.
It is.
So all these bad guy pain clinics are hurting the good guy pain
Yes.
clinics and affecting people's ability to live their best life.
Absolutely.
So I love that. Those other ones, those bad guys,
Yes.
are probably not caring how many doctors you're seeing, what
Oh, no.
medications you're taking. Don't
No.
ask for any reports or labs or anything. They don't want to get to
Absolutely
the
not.
bottom of it and help
Yeah,
you.
absolutely
They just
not.
want to be a
Yes.
pill pusher.
And what they'll say is when you call them, a lot of times they'll say, okay, come in on Monday anytime or come in on Tuesday anytime. Don't worry about bringing your insurance. We're cash only place. Those are the types of
Cash
places that you want to avoid. You want someone who, like, if you're going to another dermatologist or primary care physician and they say to you on the phone, the secretary says, okay, what insurance do you have? Who have you seen before? What other types of diseases do you have? All this information is really important for us because we try to pull all of that together when we're setting up what regimen of care for the patients.
And are y'all regulated as
Yes.
a pain center?
Oh,
Do you get
absolutely.
surveys?
Absolutely. We're regulated, and we're actually part of the North Fulton Hospital, so we actually even have them watching over us, too.
But are all pain clinics regulated, or is it
Yes.
only if you're getting government funding? If it's cash only, are they not regulated like you all? Or
It's hard to say. Like for places like us, yes, we're regulated very closely. We're always making sure that the three physicians and myself are always making sure we're doing the best for the patients. Just in case, there's been times in which you will have DE agents walking in where they're undercover. Pharmacies are watching, pharmacists are watching, pharmaceutical companies are watching to see what's being distributed, what's being
well, good.
given.
I'm glad, because I hate the idea of the whole pain clinic industry
Oh,
getting
absolutely.
marred by these folks that are abusing the system. And we have
Absolutely.
a job to do
Well, you
to
know-
get our fellow Americans comfortable.
Absolutely. And the problem is, too, is that a lot of our patients who even come to us, who have been coming to us for years, once I sit down and talk to them for a while, they'll look at me and they'll say, I hate having to do this. I hate having to take pain medicine because I hate the fact that people out there don't understand and they think I'm an addict or they think I don't need this medicine. And the one caveat with pain is that many people don't see the pain, so they don't understand why someone would need the medicine. Like, for instance, if you have a patient who is a cancer patient and they go through chemo and radiation and they lose their hair, other people will see that and have an empathy for that. However, if you have a pain patient who's chronic and they've had some type of back surgery, for instance, or headaches, for instance, they'll just be walking down the street and you wouldn't know what type of pain they're in by just seeing them.
And again, then you get that psychological, it's just
Right.
psychological. She needs to get her act together.
Exactly.
Drives me crazy.
Absolutely.
Because I know people. I know an ex-Navy SEAL who gave to his country and in a very dangerous way and injured his back while fighting for our country. And he cannot get his pain under control.
Oh, absolutely.
And there's talk, oh, he's a drug seeker. No, he's not.
No, he's
He don't want to
not.
be high.
Right.
He wants to be pain-free.
Exactly. And that's what the difference is that when we do our procedures on our patients, or if we do prescribe pain medication, the difference is that if you have a patient who is in pain, 9 times out of 10, when you do a procedure, when you give them the pain medicine, it's not going to make them high. What it does is it helps bring them back down to a more of a normal or stable level where they have improved quality of life. When the pain medicine goes to someone who is young and doesn't have any issues, when they take it, a lot of times it gives them that euphoria. So, and we're always in our office, always talking to patients about, does this make you feel groggy, drowsy, a little lethargic? Because it can always be tweaked, and that's our job, is to step in with the patients and make a good team between all of us and get them the proper procedures done, give them any medicines if they do need that will have the least amount of effect to them in a negative way, but improve their quality of life.
And when you have pain, I used to travel with a nurse practitioner when I worked in hospice and selling hospice to get people to understand what hospice was. Long time ago, before hospice was widely known about. And I could give her a presentation like I was her, but she would make this motion and say, you're putting the bagel in the toaster. You're in a hurry. You're trying to get to work. You pull the bagel out. You go to cut the bagel. Instead of cutting the bagel, you cut your finger.
Right.
Well, now all day long, that is the only thing your body can think about. When you go to the bathroom to unzip your pants, when you go to type on the computer, whatever it is you're doing, every ounce of energy within your body is going to that spot that hurts. You all know what I'm talking about, don't you? And that's exhausting.
Yeah, absolutely.
For
That's
your body.
The best word.
And that's why people in pain, unaddressed pain, are going to fail in health soon if that isn't fixed.
Absolutely.
Because the body is too tired to get you better after a while. And then all kinds of other things start happening.
Right.
I know a little bit about pain. I don't know if you can tell. And it drives me crazy because I want to get people out of pain. That's why I went into hospice in the first place.
Right.
I cannot stand to see people in pain. I don't think there's ever a reason for us to keep people in pain.
Right.
And the other thing that drives me crazy is out of surgery. Everybody's so worried about people getting addicted. They'll only prescribe you X amount of pills and the lowest dose. Well, I'd like to send you home after getting cut wide open with the lowest dose and X amount of pills on a Friday when you're not around for the weekend, and you sleep that first night and have to call in and say, I need more.
Exactly.
Make me feel like a druggie and an addict and inadequate that I'm not brave enough to fight this pain.
Exactly.
Drives me crazy. My doctors know now. I've had 2 surgeries last year, and my first question is, okay, you're not touching me unless you tell me what your pain medicine regime is going to be when you get me out of this procedure.
That's a very smart way of looking at it.
And I want everybody to do that because I've had a rough couple of years. My sister had a hysterectomy. For all intents and purposes, my stepdaughter had shoulder surgery. My son had sinus surgery. I had melanoma removed and then had an emergency appendectomy. I know a little bit about what you get sent home with. And I cared for 3 people before anything happened to me. And caring for people in pain is even worse because your hands are tied.
Can't do
and
anything.
all I wanted to do was give them 2 pills instead of 1.
Absolutely.
And that's not healthy because then they have too much Tylenol. We have got to educate physicians, healthcare providers. Orthopedics are the worst, I think. I love them. They do a good job, but they don't like pain medicine. So anyway, I digress. But we have a long way to go before we really tackle how to help people in short-term acute pain without worrying about addiction and chronic pain so that we can get people living and contributing to society again.
Absolutely.
Not to mention end-of-life pain. I think hospice does a pretty good job of that.
Yes, absolutely.
Because we don't care if you're going to get addicted. But we still struggle with a lot of doctors, and we still have phone conversations that say, look, they're here because they don't have 6 months to live. We're
Make them
not worried
comfortable.
about them becoming addicted.
Right. Make them comfortable.
So, what are your thoughts on that? Now that I'm off my soapbox here, I'm sorry, Michele.
Well, what it is I agree with you that for post-op pain, first and foremost, if the pain isn't controlled well enough, what happens with the person is that you're so tense because of the pain. And just like you said, you're constantly thinking and worrying about it. The body can't heal itself as well as it should, or it takes longer. If the proper medicines are given to the person, you can relax, you can heal, you can rest and sleep and recuperate from it. That's the biggest part with post-op.
And get off the pain medicine quicker.
Right,
because
exactly.
you did the right thing the first few days or weeks.
Exactly. Medications can easily be given where it's a little bit more in the beginning, and then it's just titrated down, and the patient can be weaned off of it as they do better. And we see a lot of our patients who have gone for hip replacements or knee replacements, and in the beginning, they'll have a little bit more higher doses, and then it's slowly brought down. But we watch them closely because the thing is, too, is that after the surgery, some of them, they have to do physical therapy. Mm-hmm. So you want to make sure that they're covered with medicine during that time, because just like you're saying, you don't want them walking out of the hospital or out of an outpatient with 2 days worth of medicine. It's just not going to cut it.
Right.
They need something to help them be proactive and be productive during their own healing process.
I remember when I gave birth, I was in tremendous amount of pain afterwards, and I won't go there, but I remember the doctor said, "Oh, okay, let me give you some Tylenol." Well, I about ripped his head off. I said, "You try getting I don't need Tylenol. Who do you think you are?" I mean, it's crazy to me. We need to educate physicians so much better about pain management.
And also educate the patients, I think, is a really big part of it, is taking the time to sit down with them and say, okay, look, we're going to give this to you for this period of time for acute or for chronic. Okay, this is what we're doing for you. These are the potential side effects. This is why I need you to take it the way I'm ordering it. Right. This is what I need you to look for. This is what I need you to call me about.
With the caregiver.
Right,
yes.
Absolutely. So that way they have the knowledge and they're part of their own care. I sit down with our patients, our doctors sit down with our patients, and we'll say, if we're talking about medications, for instance, okay, these are our options. I really don't think you're good for this one, or I really think this one will work better for you because of these reasons. Patients and people nowadays, everybody can look online and look up and be educated. So why not make them a part of their own care?
I think we're afraid of taking our doctor off because we're going to be going under and our life is in their hands. Because I had a little bit of that. I wanted to be the nice girl that he liked, But every single person that's going in for a procedure, you can't just look at the x-ray, talk about the procedure. You gotta discuss the pain management regime when you get out of the hospital.
Absolutely.
We have to take a quick break. I always go over. But stay with us because we're going to come back with Michele Chen from North Fulton Pain and Spine Center. And if you want to get in touch with her, you can contact them at 770-751-2719. You can also check them out on the website, www.northfultonpainandspine.com. Not all pain clinics are shady.
Yes.
There is a need for them. There are good people in them. And seek out Michele and North Fulton Pain and Spine Center if you want some answers.
Yes, we are
Stay
here.
with us. We'll be right back. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thanks for staying with me. I'm Jean Pete, and I'm back with Michele Chen with North Fulton Pain and Spine Center. We talk about all things pain, acute pain, chronic pain, all my issues with pain regimes after surgeries and how I want to be an advocate for patients in pain. And Michele is giving us some great information about how North Fulton Pain and Spine Center addresses pain. in an acute situation and in a chronic situation. So lots more questions for you. Before the break,
Absolutely.
we talked about the fact that not everybody is an addict. They are in pain and they need to be made pain-free. We also talked about chronic pain, and lower back pain seems to be the most prevalent, but headaches and migraines and face and neck pain, and that can all kind of be related to how we live our lives.
Right.
We're also here in the studio with a colleague of mine, Cheryl Giordano. She was just here observing, but she had a question during the break, and I said, no, you can't ask it. You got to wait. We'll put you on the radio and ask it live. So, Cheryl, you had a question for Michele prior to us taking a break.
I do. This topic just became very personal for me. My mother, who's 84, is diagnosed with lung cancer. And and I feel like her pain has not been managed well.
Yes, ma'am.
For two reasons. One is her reluctance to question the doctor.
Right.
There's that, the doctor is above, or, that they're not anybody to be questioned, frankly. And the other is that when she got the medication, she thought that to be a good patient, she shouldn't take as much as she was parsing it out to herself. And my father, who's her caregiver, who's 85, he was also, parsing it out to her. And so, is there such a thing as getting ahead of the pain? I've heard people say that, and not waiting until you're in acute pain.
Absolutely.
And what I loved you saying is that you sit down and educate.
Yes, ma'am.
Education gives us knowledge, which gives us a lot of freedom and choices.
Exactly.
So can you talk a little bit about that?
Sure. So we do have a lot of our patients do also come to us with some form of cancer. And it's our job to, again, make them as comfortable as possible and to want the patient, again, to be part of the team in their pain management. What a lot of times our patients will come to us, again, if you have a patient who's older, who throughout life has maybe taken a few Tylenols or ibuprofen, they're so reluctant and hesitant, and it's understandable not to use the pain medicine. They go online or they see on TV people overdosing and how horrific it is. But if it's being given to someone from a physician for a good reason, that's why they should take it when they need it. We always will tell everyone, feel comfortable with knowing that you can use this medicine. It's our job to make sure we're giving you the proper doses, telling you how often you can take it, so that way we're the ones helping monitor any potential side effects, and that way it gives the patient a little bit more freedom, or at least a little bit more comfort in knowing that they can use the medicine. Because people do, they'll hold off taking it, and then the pain will start to spiral and get out of control.
In the middle of the night, and then no one sleeps.
Exactly, and then no one can heal, no one can feel better in the morning. But if people will take their medicine, I'll always tell them it's a fine line between taking that medicine when that pain is first starting to kind of come on, and you pay attention to your body, and if you're thinking, okay, this is gonna not feel good, or this is gonna kind of get out of control a little bit, feel comfortable in knowing to take the medicine. That's what it's there for. People won't get addicted to it. That is not every single person who comes in our office. That's not the goal, is to get people addicted. It's to educate them have that freedom to take the medicine when they need it, and to have a better, improved quality of life when they use it. So again, our job is we always try to sit down with them, answer those questions, make the caregiver, make the patient understand it's okay to use these meds. There's not a problem with it.
And sometimes, especially when it's women, well, I don't know, I guess I shouldn't say that, but I'm assuming because we've grown our whole life taking care of other people. Mm-hmm. You know, they relied on us.
Right.
We were the rock for them. Mm-hmm. When we're in pain, we don't want them. We're still trying to protect them.
Right.
You know, no, I'm good. I don't need it.
Right.
But when that pain gets ahead of you, you're inflicting concern, worry, sadness on the caregivers.
Absolutely.
And I address this like I've addressed it with family members on hospice. You know what? You couldn't live seeing your son, your daughter in pain. You would want to do something about it, or you would feel helpless and not worthy.
Right.
Please don't put your loved one and your caregiver in that position.
Right.
If you're in pain, they want you to feel better.
Sure.
You're actually still nurturing, loving, and caring for them by letting them care for you.
Right.
So, Cheryl, on your side, I would say that's the conversation you need to have with your mother. Hey, listen, you're not in this alone. We're in this with you, and you're not letting us help you.
Right.
I think obviously that is the case this morning. I didn't see that in such a personal way, but it is. It's the conversation I need to have with her, and to let her know it's okay.
It's okay. That's what it's there for.
It's okay, and the pain is to be expected. What I like too about your clinic, it sounds like it's a dialogue too.
Yes.
My mother's reluctant to call the doctor's office. It sounds like your office is more, they're part of the care plan.
Oh, absolutely. We have patients who will email us, stop on by with questions, call us all the time. And I always tell them, if you can't get in touch if one of our doctors is in a procedure, call me. That's what I'm here for. I'm here. I'll answer the questions. If I can't, I'll grab one of our guys and see what the answer might be for them. And the other thing, too, is with a lot of the patients who also are a little bit more reluctant when it comes to the pain medicines, a lot of times our physicians will step into and talk about, okay, why don't we talk about, is there a procedure option that we can do for you? Like, for instance, there's nerve blocks, there's epidurals, there's injections that we can give. And a lot of times if a procedure is done, that will hopefully bring down the level of pain. So say if someone walks into us with a pain of 10 out of 10, and our doctors will talk to them and say, okay, well, let's try an epidural. Let's try what we call a radiofrequency ablation. That's a nerve burning. And we can get down that pain maybe to a 6 or a 7 out of 10. First thing is that if they need pain medicine, they may need a lot less, which may make them feel a little bit more comfortable. Also, when they do take it, it will work better because instead of that pain medicine working against a pain of 10 out of 10, now it only has to try to tackle a pain level of maybe 6 out of 10. So that's another option too for a lot of people, is there are procedures out there that can help bring down the overall pain and keep them a little bit more stable for many months. That way they don't need as much of the pain medications.
So let's talk about some of these procedures. Yes. What does the epidural, because you say epidural, you think woman in labor.
Women in labor, yeah.
Yeah. Are you talking about treating back pain?
Yes. So what we do is there's the three different, you have your cervical, your neck, your thoracic, the back where the lungs are, and then your lumbar spine. Our doctors will bring in patients. We do about 3 procedures a year or 3 epidurals a year for many of our patients because the amount of steroid will be monitored. An epidural will consist of an injection into the epidural space in the back where we give them a little bit of steroid and a little bit of pain medicine, typically like a little bit of numbing medicine. And the job of the two of them together is that the steroid will help decrease some of the swelling in the back of the spine, and then the pain medicine can get through there and relieve some of the pain. Many of our times when we have pain in our back, a lot of times it's due to either nerve or muscle or bone pain. Those are the most common ones. When you're giving an epidural to a patient, a lot of times those patients are having sharp shooting electricity type of pain, maybe shooting down their legs or shooting into their shoulders and arms. That's nerve pain. And what happens is that in the spine, there's a very thin canal and the nerves run through that. When the spine moves in certain directions, it can pinch those nerves a little bit. The nerves get really upset about that, and they'll send out messages letting you know, again, that sharp shooting electricity type of pain.
It's like that sciatica coming straight down your leg.
Exactly. So the doctors will bring in patients. It's a very safe procedure that our doctors will do. We'll do many patients, again, at least 3 times a year or the
But
for
that would
them.
be my question, because does it last that long?
It will. Everyone's a little different, and I know
I
that
don't remember it
sounds.
lasting that long when I was having babies.
Yeah, and that one when they pull out. This one, when they give it to the patients, it's meant to last a little bit longer. So I know, and it's kind of sounds like a gray area, but patients will have weeks to months of relief of pain. If patients are seeing that the epidurals aren't working as well as they were hoping, another suggestion that the doctors will talk about is the radiofrequency ablation, and that's the nerve burning. And I know that sounds scary, but what it is
Sounds painful.
Yeah. But what it is that where the pain is coming out, that sharp shooting type of pain, the doctors will go in and they will cauterize the nerves. It's very simple type of procedure for our patients. It's a 2-step process where first they get, it's called a medial branch block, and the doctors will pick maybe 1 or 2 areas that seem to be giving the most pain to the person, and they'll go in there, and if the person gets about 60 to 70% improvement of their pain, they'll bring them back a few days later and do the full-blown cauterization.
So what you're doing is you're taking the nerves and cutting off the connection,
right?
So they can't. So it stops you from having that pain flow through your body.
Exactly. The message can't go through that nerve anymore.
The message. Right.
And what happens is that it's like the doctors will, where they cauterize it, that's where the message will stop, and it doesn't go shooting down the legs anymore or shooting into the arms.
But you'll still
everyone.
have pain in that one area. No?
For about. Usually, again, the nerves get a little upset about it. So for the first 4 weeks, it will be a little uncomfortable. Most of the patients, when we'll tell them, okay, this is what we're going to do, for the first about 4 to 6 weeks, it's not going to be horrific pain, but it's still going to feel like we didn't do anything to improve your pain. So the difference between the epidural, when patients walk out of our office, 9 times out of 10, they're thinking, okay, this pain is better, it's improved, I'm good to go. With the radiofrequency lesioning, they'll walk out going, oh gosh, I didn't feel like anything was done. But after about 6 weeks, when that nerve calms down, people have told us they'll get about 7 months to 8 months improvement of their pain.
That's
which is
great.
phenomenal for someone in chronic pain.
And I imagine a lot of people that come to you don't know that's available to them.
Absolutely. There's so many things that we can do nowadays. For knee pain, our doctors do something called a genicular nerve block. Similar type of procedure. They go in and they cauterize the little nerve in the knee that's sending out that message of pain into the knee. For people with osteoarthritis, it's a very simple procedure for our doctors.
Let me ask you this. On average, and I know I'm asking you another loaded question, but how long have people suffered with back pain, let's say, before they come to see you?
Most of them, when they've come to see us, it's been years.
See, and if they had gotten this taken care of far earlier,
Right.
then they could have lived a much greater quality of life, and then their health probably wouldn't have deteriorated in other factions because
Exactly.
they've gone so long in pain.
Exactly.
And really and truly, I mean, I thought you had to move mountains before anyone would even think about a nerve block.
Oh no, usually what we do, our thought process when we see our patients is, let's try the holistic first. Let's talk about massage therapy,
Well, sure,
acupuncture,
absolutely.
all of those to the hot cold packs. Let's try anti-inflammatories. If that doesn't work, let's talk about procedures, because if that gives a longer relief of pain for someone without having to use a lot of pain medicines, that's an option too. And then third, we'll say to them, okay, you know what? Let's give you some type of pain medicine. And everyone is different, so it's not like we'll hold back from saying, okay, here's some pain medicine. We'll definitely, if someone needs it, we'll definitely give it to them. We're not shy to do that.
But your expectation is that they are in constant allowing you to monitor them.
Yes. Oh, yes, absolutely.
Because if they all of a sudden disappear, well, then hello, that's why people are worried that you're drug seeking.
Right. And
that's a key indicator, I would
absolutely.
say.
And we do multiple things on our end. We do urine drug screens on our patients sporadically throughout the year. We do pill counts on our patients, in which we expect them to come in every month with their bottles, and they have to be the current bottles with the pharmacy information on it. We'll count the pills, give them back to the person, but it's a way for us to help monitor them.
And I suspect that the person in pain doesn't mind doing that because you're taking care of them finally.
Absolutely. They actually appreciate it because they know the ones who truly are in pain, they're more than willing to do whatever it is that it takes in those lines, because they're going to be honest with us. They're going to say, hey, I don't know if this is working. Can we talk about another option? So, again, we always try to instill communication in our pain patients, because that's one of the biggest things that will help improve their pain.
So there's just a couple of things I want to make sure, just to take a minute here, that our listeners think about. And one is, if you know someone that's going to a pain clinic who's been suffering for a long time, it could be that they're finally going to get the answers they need. Let's not judge folks that do go to these pain centers.
Absolutely.
Two, if you've been suffering in pain for a long time, lower back pain, anywhere, I had a doctor on a few weeks ago because I'm living what I'm telling everybody not to do. But I walked every day for about 10 months to lose about 70 pounds, which was wonderful. But I created plantar fasciitis 3 years ago.
Oh.
And I'm just now seeing a doctor. So now I have chronic plantar fasciosis.
Yes.
And don't let it go that long.
Absolutely not.
To get it taken care of, because it's your quality of life.
Absolutely.
And let's not judge folks. I don't like hearing it's psychosomatic. It's all in their head.
It's not.
When people can't function to the point where they're disabled, whatever that term means, something's going on with them. And just because we don't know what it is, it doesn't mean there's nothing. We don't understand the body fully.
And our job is to sit down and talk to them and say, okay, you know what? Maybe it's time for an MRI. Maybe it's time for a CT scan. Let's find out what's going on here, so that way we can address it properly. If we don't see anything on the MRI or CT scan, then okay, maybe it's muscular. Maybe it's something a little bit different. But don't let it go where it's so long and not being taken care of.
And then once you're there, you're being monitored, you're getting all the tests, you're seeing some results. Then you can show folks, hey, look, they got to the bottom of it. This is what they gave me, and it's working. So clearly there was something wrong, or it wouldn't have worked.
Exactly.
And how nice is that? Okay, great. So we talked about epidural and I don't remember what you called it.
Radio frequency ablation.
Radio frequency ablation. I love that. And that's like the nerve block.
The nerve block.
But you also have here dorsal column stimulator placement. What's that?
It's a really interesting way of dealing with chronic pain for a lot of our patients who have back issues. It's for the patient who has had chronic pain for a really long time. Basically, it's a small little machine that's about maybe 2 inches by about maybe 1 inch. And what it is it's put in the patient's back area. It has leads that go up into the spine. It's very safe. They've been doing it for years.
How big is it?
It's about maybe 2 by 1 inch. And it goes above.
So like one of those like little Fitbits sometimes that people wear to check and see how many paces there. Okay.
And they do a trial first, the same way as with the radio frequency, and then they'll go ahead and they'll do the regular procedure for the patient. So what it is that it's placed above the patient's hip area, where we all have a little bit extra.
Yeah.
Oomph, if
Speak
you will.
for yourself.
Yes.
No.
And so it's nice and cushioned in there, and then the leads will go up into the spine. And what it does is it makes the brain rethink the way they feel pain. So instead of pain being sharp, shooting electricity, stabbing, it changes the way the pain is felt in the body, and it's almost like a little bit of a tingling sensation. The machine can be changed. There's different programs. There's different intensity levels. So that way someone they'll still feel something down there. Again, that tingling type of sensation, but it's not that acute, debilitating type of pain.
Mm-hmm. So we're sending a different message.
Yes.
Huh, that's fascinating. I wonder how. That's fascinating. So maybe pretty soon with the advancement in technology, we'll just send a message that everything's numb and you're fine. I need one of those easy buttons.
We do, don't we?
And then I'm not even going to try kypho.
Okay, a kyphoplasty.
Yeah.
Kyphoplasty is for our patients who have had some type of injury to their spine and they have a compression of their vertebra in their back. Excruciatingly painful for our patients. It usually happens to some of our older population. Just a normal trip and fall can do it, and it just crushes one of the vertebrae in the back.
Is that when you see folks walking, leaning forward?
They can. A lot of times these patients, by that time, they're not even able to walk. They'll be coming into us in wheelchairs, and they'll have x-rays and MRIs done at that time, and literally it's just flat back there. So what our doctors will do is they'll go in, and patient is under anesthesia. We have 2 little surgical suites in the back of our office, and our doctors will take almost like it's a small little injection, needle I should say, and they have a balloon, and they put the balloon in, and the balloon blows up the vertebral area to relieve the pressure again, and they put a form of cement in the area. So when the amazing thing is when the patients wake up, they're pain-free. Immediately. We had one sweet little lady.
Oh my God, that's wonderful.
We had one sweet little lady, I believe she was in her late 80s, and she had a horrible fall, and she had a compression to her neck and her low back. So the doctors talked to her and said, okay, which is the worst, because we can only do one at a time. And she said, my low back, definitely. So the doctors went in and they fixed that one. When she woke up, she had no pain to her lower back, just the pain to the neck.
I love that. That's wonderful that there are so many options. And again, I think they're just living with it. And I'm so glad that you're here today so that we can share that there is help out there.
Absolutely.
And if you're willing to be compliant and be monitored, we can help you.
Absolutely.
No matter what age.
Yes.
I mean, she was what, 84?
She was in her late 80s.
That's great. Late 80s. That's great. Okay, well, again, we've run out of time. Happens all the time. I still have. I could talk to you for another hour. Thank you so much for joining us, Michele.
Thank you. I appreciate it.
Again, Michele is here from North Fulton Pain and Spine Center. They're located on Hospital Boulevard, right in Roswell, North Fulton Hospital, correct?
We're on their campus.
And you can reach them at 770-751-2719. Check them out on their website, www.northfultonpainandspine.com. And we're speaking today with Michele Chen, so you can email her if you'd like. Michele, Michele, only one L, .Chen, Chen, at Tenet Health, and that's TENET health.com.
Yes.
Thank you so much for joining us.
Thank you. I appreciate it.
I hope if anybody listening is suffering in pain, they will contact you and get better, and I can't wait to hear the stories.
Yes, we're here for them.
Thank you all.
Thank you.
Bye-bye. I'm Jeannie Pete. Thanks for listening. Have a blessed day and week ahead, and listen here same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.